Common cold is a viral infection of the upper respiratory tract affecting the nose, throat, and sinuses. More than 200 viruses can cause common cold. However, the majority of colds are caused by rhinoviruses. Colds are highly contagious and are usually self-limiting. They can spread by hand-to-hand contact with someone who has a cold or by sharing their contaminated objects such as utensils, towels, toys. Also, it can be spread through droplets of air when someone who is sick coughs, sneezes, or even talks. So what happens here is that when you touch your eyes, nose, or mouth after such contact or exposure, the virus can directly enter your body through your mouth, eyes, or nose. When viruses that cause cold bind to the receptors on the respiratory epithelial cells in the nose and sinuses, they initiate the inflammatory response, causing a variety of symptoms, as you are seeing in this diagram. So that we will have an inflammation, we will have a vasodilation, which will cause an obstruction of the nasal passages, we will have excessive cholinergic stimulation, causing mucus secretion and causing rhinorrhea, bronchoconstriction, which causes cough, and all of the other symptoms as well. Symptoms appear usually 1 to 3 days after exposure, and the cold is most contagious 1 to 2 days after the symptoms develop. Sore throat is the first symptom to appear, followed by nasal symptoms which dominate by day 2 to 3, which include nasal obstruction, runny nose, tender sinuses and palpitations. During the first 2 days, clean and watery nasal secretions are released. As the infection progresses, the secretions will become thicker and the color may change to white, yellow, or green color. This is normal and does not mean you need an antibiotic. When the cold begins to resolve, the secretions again will become clear, thin, and watery. Cough might appear in few cases by day 4 to 5, and low-grade fever and some symptoms may last 7 to 14 days, and of course they must be improving with time. The complications of common cold include sinusitis, middle ear infection, bronchitis, pneumonia, asthma or COPD exacerbation. Of course, common cold is not treatable as we don't have an antiviral oral medication. However, as we mentioned, it is self-limiting, so the medications will tend only to relieve the symptoms, and of course along with following some non-pharmacological measures and some other measures to prevent transmission. So how do we prevent transmission? Frequently washing your hand with soap for at least 15 seconds, using facial tissues to cover your mouth and nose when coughing or sneezing, using antiviral products to clean surfaces. Non-pharmacological therapy for adults include a lot of fluid intake, tea with lemon and honey, chicken soup, and others. Drinking plenty of fluid is important for ensuring a speed recovery as it helps to loosen mucus in the nose and relieve congestion. Avoid caffeinated drinks or alcohol, which can contribute to dehydration, and of course get adequate rest. Increase the humidification with a steamy shower may help decrease the congestion by increasing the moisture in the air. Saline gargles may ease sore throat. Usually you can prepare it at home by mixing 8 ounces of warm water mixed with 1/4 to 1/2 teaspoon of salt. Saline nasal sprays or drops soothe the irritated mucosal membranes and loosen encrusted mucus. And we mentioned a lot of saline nasal sprays and we talked about them in the last videos and how we should use them as well. Local anesthetic products containing benzocaine or diclonine hydrochloride are available for the temporary relief of sore throat. Local anesthetic, local antiseptics, usually containing menthol or camphor, they are usually help in sore throat. In addition, sucking on hard candy. Most known one is the Dicalene lozenge, which is usually given 1 every 2 to 4 hours as needed. Medical devices such as Vicks Breathe Right nasal strips are marketed for temporary relief of nasal congestion and stuffiness resulting from colds. These devices lift the nares open, enlarging the anterior nasal passage. Variety of aromatic products claim to ease nasal congestion by producing soothing odors such as camphor and eucalyptus. Now, how to differentiate between common cold and similar conditions? We already mentioned in the last video how to differentiate between common cold and allergic rhinitis, so we're not going to mention it here. However, how do we differentiate between common cold, sore throat versus the bacterial pharyngitis or tonsillitis? So we need to check for symptoms that are suggestive of viral infection, for example, conjunctivitis, cough, rhinorrhea, hoarseness. If they are not presented, we can consider the center score. This is the center score, and usually we see if there's a temperature, if there's absence of cough, swollen tender anterior cervical lymph, tonsillar swelling, and so on. This indicates a bacterial infection. Having a score 3 or more is subjective of a gas pharyngitis, so they need to perform the rapid antigen determination testing. So if it's positive, then we need to treat with antibiotic. Starting off with the medication, we have decongestant. Decongestant stimulate the alpha-adrenergic receptors, causing vasoconstriction of the blood vessels, thus decreasing the mucosal edema. The systemic decongestant include pseudoephedrine and phenylephrine. Topical decongestant, which are usually given as intranasal, include the short-acting phenylephrine, nafazoline, which is also used ocular, tetrahydrozoline, which is also ocular, and we have the oxymetazoline, which is usually intermediate-acting and long-acting. An important note about intranasal inhalers is that they lose efficacy after 2 to 3 months, even when tightly capped, because of dissipation of the active ingredients. Acute overdose of systemic decongestant can cause excessive central nervous system stimulation and cardiovascular stimulation, where increasing in blood pressure, tachycardia, arrhythmia, and palpitations occur. Adverse effect, however, to topical decongestant include burning, sneezing, stinging, and local dryness. Also, rhinitis medicamentosa, which also we talked about in the allergic rhinitis video. So to prevent this rhinitis medicamentosa, topical decongestant are usually used for only 3 to 5 days. However, if someone used them for more and rhinitis medicamentosa have happened, then we need to treat it. We slowly withdraw the topical decongestant 1 nostril at a time, replacing the decongestant with normal saline, which soothes the irritated mucosa. If needed, use a topical corticosteroid and a systemic decongestant, and the mucous membrane returns to normal with 1 to 2 weeks. The frequency of the decongestant can differ from one formulation to another. However, it's usually used 2 to 3 sprays per nostril. Now, what about antihistamines? Evidence does not support the use of antihistamines, antitussives, and expectorants for the treatment of symptoms related to cold. However, if we want to use antihistamine, we usually here use the first generation antihistamine to have the antimuscarinic action that we want. And first generation antihistamine anticongestant combination showed some benefits in adults and is found in many drugs with combination with analgesic as well. The cough associated with cold is usually non-productive, and the use of antitussives like codeine and dextromorphin and expectorant have questioned efficacy in cold and are not usually recommended, as we mentioned earlier. Managing congestion can relieve headache. However, if the patient is complaining about a pain or headache or sore throat, we can give systemic analgesics such as aspirin, acetaminophen, ibuprofen, or naproxen. They are effective for the treatment of aches, sore throat pain, or fever associated with colds because, of course, they are also antipyretic. However, if we are taking something different than acetaminophen, then we want to monitor the blood pressure in hypertensive patients. Now, what about the complementary and alternative therapies? High local concentration of zinc ions appears to block the adhesion of human rhinovirus to the nasal epithelium and are also thought to inhibit viral replication by disrupting the viral capsid formation. Clinical trials conducted that zinc decreased the severity and or duration of symptoms in adults that used a rigorous administration schedule that started within 24 to 48 hours of symptoms onset. The efficacy and safety of high-dose vitamin C supplementation for prophylaxis and treatment of cold has been debated for more than 60 years. Using vitamin C as treatment after the onset of cold was not effective at reducing severity or duration of symptoms. If the symptoms persistent for more than 7 to 14 days, or you experience new onset fever, facial pain, exacerbation, persistent sore throat, chest pain, worsening of the symptoms, cough that doesn't improve within 7 to 14 days, then you should consult your physician. Now I want to talk about the special population. Starting with infants, non-prescription cold products should not be given to children younger than 2 years because of lack of efficacy and high risk for adverse events and even death. You usually go as a first-line treatment for the non-pharmacological therapy, which includes upright positioning to enhance the nasal drainage, adequate fluid intake, increase the humidity of the inspired air, irrigating nose with saline drops, and clearing the nasal passageways with bulb syringe to prevent accumulation of mucus that might interfere with eating or sleeping. Because most colds are self-limiting with bothersome rather than life-threatening symptoms, many clinicians recommend non-drug therapy during pregnancy and lactation as well. The pregnant woman is advised to avoid products labeled as extra strength or maximum strength or long-acting, as well as combination products. Systemic decongestant decreases fetal blood flow and should be avoided. However, there is no clear association between birth defects and the use of intranasal decongestant. Studies show that oxymetazoline intranasal is the preferred topical decongestant during pregnancy. Pseudoephedrine has found to be compatible with breastfeeding and to be the preferred decongestant, but some studies show that it can cause irritability in 20% of the infants. Pseudoephedrine might decrease milk production, so mothers should monitor their milk production and drink extra fluid as needed. Nasal preparations containing xylometazoline and nafazoline could be used in lactating, but mothers should monitor their milk production and drink extra fluid as needed. Analgesics do not increase the risk of birth defects when taken in the first trimester. However, NSAIDs are associated with an increased risk of intracranial hemorrhage and premature closure of the patent ductus arteriosus and should be avoided during the third trimester. Aspirin should be avoided during lactation as well as in children less than 16 years of age. Why? Because of risk of developing Graves syndrome, which is the swelling in the brain and the liver. However, acetaminophen is safe during pregnancy and lactation. The following figure shows an overview about every type of nasal route formulations and how are they used. ACE inhibitors should never be given with NSAIDs, as NSAIDs will cause decrease in the efficacy of ACE inhibitors, and thus this will lead to increase in blood pressure. In addition, the combination of ramipril hydrochlorothiazides, which are used for management of hypertension, along with NSAIDs, this combination may result in kidney injury, so they must not be used together. Oral combination of decongestant and antihistamine is usually preferred than either monotherapy alone. Topical decongestant and local, and thus we need to only monitor the blood pressure. However, we can't give the oral decongestant with someone having hypertension because they will further decrease the blood pressure. We always counsel the lactating woman that if she is taking NSAID, it should be taken immediately after breastfeeding or before the infant's longest sleeping period. Oral decongestants are not given in pregnancy as they are vasoconstrictors and tend to decrease the blood flow to the fetus. Also, we might go to topical decongestant with oral antihistamine, knowing that oral antihistamines are first generation and tend to cause sedation, so they must be taken at bedtime. Blood glucose concentrations need to be monitored closely since some studies showed that alpha-adrenergic might increase blood glucose, so use it with caution. Large amount of some antacids or medicines that increase the pH decreases the elimination of pseudoephedrine. Now, these decongestants are minimally absorbed if taken nasally. Now, these decongestants, if they are used non-systemically, now these decongestants, if they are used in the nasal route, then it's minimally absorbed, so it won't affect your blood pressure significantly. However,